Welcome to our deep dive into the fascinating world of mastopexy. You know, that surgical procedure designed to address breastosis, more commonly known as sagging.
Right.
And what's really interesting about mastopexy is that it focuses on correcting the position and shape of the breasts without significantly altering their volume.
Yeah. And it's also interesting to note the significant rise in its popularity.
Oh, yeah.
Since 2000, the number of mastopexies performed has surged by an astounding 108%.
Wow.
And in 2018 alone, over 109,000 mastopexies were performed in the U.S.
It seems like mastopexy is becoming increasingly sought after.
What?
But before we get into the surgical techniques, let's understand the underlying causes of ptosis, what leads to this drooping or sagging of the breasts.
Well, ptosis occurs due to a complex interplay of factors, primarily involving changes in the breast parenchyma and the skin envelope. As we age, the breast tissue loses volume, and if the skin doesn't contract proportionally, it leads to sagging.
So it's like a deflated balloon where the rubber remains stretched out. Makes sense. But are there specific age-related factors that contribute to ptosis?
Oh, absolutely. Different age groups experience it for different reasons.
Okay, so let's break it down.
Okay. So in younger patients, ptosis can be attributed to factors like inherently thin skin or the presence of naturally large, heavy breasts. These factors can put extra strain on the supporting structures, leading to earlier onset of sagging.
And as we move through different stages of life, additional elements come into play, right?
Absolutely. For middle-aged women, particularly those who've gone through pregnancy and breastfeeding, hormonal fluctuations play a significant role.
Okay.
These hormonal shifts can cause atrophy of the glandular tissue, while the stretching of Cooper's ligaments, which provides structural support, further contributes to ptosis. This combination of factors can dramatically alter breast shape and position.
So we've got genetics, weight, and hormonal changes all playing a part. But what about the natural aging process? I'm sure gravity doesn't help matters as we get older.
You're right, gravity is a relentless force, and it definitely exacerbates ptosis over time. Postmenopausal women in particular experience a decrease in skin elasticity and collagen production, making them more susceptible to sagging.
So it seems like ptosis is almost inevitable to some degree as we age.
To some degree, yes.
But how do surgeons assess the severity of ptosis? Is there a standardized system for classifying it?
Yes. The Retinol classification system is widely used to categorize ptosis based on the relationship between the nipple areola complex, or NAC, and the inframammary fold, IMF.
Okay.
This system provides a clear framework for surgeons to determine the extent of ptosis and tailor their surgical approach accordingly.
That sounds like a crucial tool for guiding treatment.
Yeah.
Could you walk us through the different grades within the retinal classification?
Sure. Let's start with pseudoptosis.
Okay.
In this case, the NAC sits at or above the IMF, but the breast parenchyma descends below the fold, creating a subtle droop. It's important to distinguish this from true ptosis, where the NAC itself falls below the IMF.
It's like a sneak preview of potential ptosis.
Yes, exactly. Now moving on to true ectosis. We have grade 1, which is considered mild. Here, the NAC sits directly at the level of the IMF.
So the nipple is just starting its southward journey.
Precisely. In grade 2, or moderate ptosis, the NAC is positioned below the IMF but still above the lowest point of the breast. The descent is becoming more pronounced.
And finally, we reach grade 3, the most severe form.
Correct. In grade 3, the NAC is located at the lowest point of the breast, well below the IMF. This signifies a significant degree of sagging.
Okay, so the retinal system really breaks down the severity based on nipple location. It's a simple yet effective way to categorize ptosis. But once a surgeon has assessed the ptosis using this system, what are their options for actually correcting it? I imagine there's a whole arsenal of mastopexy techniques at their disposal.
You're absolutely right. There's a wide array of techniques, each with its own set of advantages and disadvantages.
Okay.
Most of these techniques can be broadly categorized into 3 main approaches: periareolar vertical scar and inverted T-square techniques.
Let's delve into those. Starting with the periareolar technique, I imagine this is a popular choice since the incisions are strategically placed around the areola, making them less conspicuous.
Precisely, periareolar techniques are particularly well suited for patients with grade 102 ptosis, who have good skin quality and either predominantly fibrous or glandular breast tissue. These techniques aim to minimize visible scarring while achieving the desired lift.
So what are some of the specific techniques that fall under this periareolar umbrella? I'm curious about the variations within this approach.
One commonly used technique is the crescent mastopexy, which focuses primarily on repositioning the nipple. It involves removing a crescent-shaped piece of skin above the areola and then suturing the remaining skin together. effectively lifting the nipple.
That sounds like a relatively straightforward approach for mild cases. But what about patients with more significant ptosis? Are there periareolar techniques that can address those cases as well?
For those with a greater degree of apoptosis, we have techniques like the Benelli and Gose procedures. The Benelli technique involves intricate manipulation of the breast parenchyma to reshape and lift the breast from within. It's a meticulous approach that requires a high level of surgical skill.
And how does the Gose technique differ from the Benelli? Is there something that sets it apart?
The Gose technique builds upon the Benelli approach by incorporating mesh support.
Okay.
This mesh acts as a scaffold, providing additional reinforcement to the lifted breast tissue, particularly for patients with weaker tissue or a higher risk of recurrence.
So the mesh adds an extra layer of security, so to speak.
Mhm.
It's fascinating how these techniques evolve and adapt to address specific patient needs. But with all these periolar approaches, what are the potential downsides? Are there any risks or drawbacks that patients should be aware of?
While periareolar techniques offer the advantage of concealed scars, there are some potential trade-offs. One concern is the risk of widening the areola, which can sometimes occur due to the circumferential incision.
That makes sense. Disturbing the natural shape of the areola is definitely something to consider. Are there any other potential complications with these techniques?
Another possibility is flattening of the breast or nipple projection. This can happen if too much tissue is removed or if the underlying support structures are compromised during the procedure. Additionally, there's a chance of altered nipple sensation due to the manipulation of nerves in the area.
So those are definitely factors to weigh carefully when choosing a mastopexy technique. Well, let's move on to the next category, vertical scar techniques. What makes these techniques stand out from the periolar approaches?
Vertical scar techniques, as the name suggests, involve incisions around the areola and a vertical incision extending downward to the IMF. This approach offers more versatility and is suitable for all poloxis grades, including more severe cases that might not be addressed effectively with periareolar techniques alone.
So it's a more comprehensive approach that provides greater corrective power.
What are some of the popular techniques that utilize this vertical scar incision pattern?
One classic example is the lascis technique.
This technique involves an en-bloc resection, meaning a whole section of tissue is removed without undermining. It's a straightforward approach that relies on removing excess skin and tissue to achieve the lift.
And how does the Lejeune technique compare to the lascis? Is there a different philosophy behind it?
The Lejeune technique incorporates undermining, which involves separating the skin from the underlying tissues, along with liposuction to further refine the breast shape and contour. This approach allows for more precise sculpting and can address localized fat deposits as well.
So it's like combining a breast lift with body contouring. That's an intriguing combination. Are there any other notable vertical scar techniques we should discuss?
Two other techniques worth mentioning are the Hammond and Hall-Finley procedures. The Hammond technique, also known as spare superior pedicle areolar reduction, cleverly positions the NAC on an inferior pedicle for enhanced support, minimizing the chance of apoptosis recurring.
So it's like creating a more secure anchor for the nipple. And what of the Hall-Finley? Does it have a unique characteristic as well?
The Hall-Finley technique utilizes a medial or supramedial pedicle, which refers to the location of the blood supply and supporting tissues for the NAC. This technique is particularly versatile because it can be combined with augmentation for patients who desire both a lift and increased volume.
That's a great option for those wanting a more comprehensive transformation. It seems like vertical scar techniques offer a lot of flexibility. But what are the general pros and cons of this approach compared to the periolar techniques?
One of the main advantages of vertical scar techniques is the added support provided by the inferior parenchymal closure. This helps to maintain the lift over time and reduces the likelihood of parotosis returning. However, the trade-off is a more extensive scar, even though it's confined to the vertical axis.
So it's a matter of balancing the benefits of increased support with the potential for a slightly more visible scar. Makes sense. Now let's talk about the third category, inverted T scar techniques. When is this approach typically recommended?
The inverted T technique, characterized by its anchor-shaped incision, is typically reserved for cases of severe apoptosis, or when patients have compromised skin quality, such as significant laxity or stretch marks. It's a powerful tool for addressing challenging cases that might not be adequately corrected with the other techniques.
So it's like the heavy hitter in the Mastopexy arsenal. What are some of the key considerations with this technique?
One important aspect is ensuring adequate parenchymal support for long-lasting results. The Wise pattern skin incision, often borrowed from reduction mammoplasty, is commonly used in this technique. It involves removing a substantial amount of skin and reshaping the breast tissue, essentially providing a new foundation for the lifted breast.
That sounds like a pretty extensive procedure. How does the inverted T technique stack up against the other approaches in terms of its pros and cons?
The main advantage is its familiarity among surgeons and its predictable results, especially in complex cases. However, the trade-off is a greater scar burden, which includes a horizontal incision along the IMF. There's also a slightly higher risk of complications, such as skin necrosis at the T-junction where the incisions meet.
So it's a powerful technique, but one that requires careful consideration and a skilled surgical hand.
Absolutely. Choosing the right technique requires a thorough assessment of the patient's individual needs and a careful weighing of the potential benefits and risks.
Before we move on, let's take a moment to recap what we've covered so far. We started by exploring the causes of ptosis and how it manifests differently across various age groups. Then we delved into the retinal classification system, which provides a standardized way to assess the severity of ptosis. Finally, we took a deep dive into the three main categories of mastopexy techniques, periolar vertical scar and inverted T-scar, highlighting their unique characteristics, advantages, and potential drawbacks.
And remember, we've only just begun to scratch the surface of this fascinating field. There's a whole world of special considerations within mastopexy, from combining it with augmentation to addressing the unique challenges of patients who've undergone massive weight loss.
You're right, there's so much more to uncover. But first, let's take a quick pause to gather our thoughts. We'll be right back to explore these special considerations and more in the world of mastopexy.
So now let's dive into those special considerations you mentioned. One increasingly common scenario is augmentation mastopexy, where patients desire both a lift and an increase in breast volume. This combination procedure can be quite complex, as it involves addressing both the position and the size of the breasts simultaneously.
Yeah, it's understandable that patients would want the best of both worlds,
Hmm?
a lifted youthful appearance and enhanced fullness. But I imagine combining those two objectives presents unique challenges for the surgeon.
Indeed, it requires careful planning and meticulous execution. You see, mastopexy aims to reduce the skin envelope, while augmentation, by its very nature, expands it. This inherent conflict can lead to suboptimal results if not managed strategically.
So it's not as simple as just performing both procedures one after the other.
Not quite. Patient selection and thorough preoperative counseling are paramount. Surgeons need to carefully assess the degree of ptosis, the patient's desired volume, and the potential interplay between these factors. In some cases, staging the procedures might be the best approach, allowing for optimal tissue healing and a more predictable outcome.
That makes sense. A strategic, individualized approach is crucial for success. Now, what about patients who have had breast implants but are now seeking to have them removed? I've heard that explantation is becoming more common, and I'm curious about the role of mastopexy in these cases.
You're right, explantation is on the rise, often driven by personal preferences or concerns about implant-related complications. After implant removal, patients frequently require mastopexy to reshape the breasts and address any residual ptosis or skin laxity.
So it's like a corrective lift to restore a more natural contour after the implants are gone. What factors guide the surgeon's decision-making in these explantation mastopexy cases?
Several factors come into play, including the degree of contosis, the amount of soft tissue coverage remaining after implant removal, and the patient's overall health and lifestyle. For instance, smoking is a major contraindication for mastopexy due to its detrimental effects on wound healing and tissue oxygenation.
Smoking seems to rear its ugly head in so many medical contexts. Speaking of potential complications, I want to touch on a topic that I know many patients are apprehensive about: the dreaded high-riding nipple. I've heard stories about this complication, and I'm curious to get your insights.
The high-riding nipple or nipple over-elevation is indeed a complication that surgeons strive to avoid. It occurs when the nipple is positioned too high on the breast mound, creating an unnatural and often difficult to conceal appearance.
So prevention is clearly key. What steps can surgeons take to minimize the risk of this complication?
Meticulous preoperative planning, precise surgical technique, and a deep understanding of the various factors that can contribute to nipple elevation are all essential. Surgeons use specific measurements and classifications to assess nipple position and guide their approach, aiming to achieve a balanced and aesthetically pleasing outcome.
Precision and expertise seem paramount. But what if, despite the surgeon's best efforts, a high-riding nipple does occur? Are there any effective treatment options available?
Unfortunately, correcting a high-riding nipple can be quite challenging. Treatment options often involve complex procedures like inferior pole remodeling, skin excision, nipple transposition, or even implant placement to adjust the overall breast contour and bring the nipple into a more harmonious position.
It sounds like a delicate surgical puzzle requiring a high level of skill and artistry. Now let's shift gears to another unique patient population: Those who have undergone massive weight loss, I imagine their needs and considerations are quite different from the average mastopexy patient.
Absolutely. Massive weight loss patients often present with a complex combination of challenges, including extreme lactosis, significant volume loss, poor skin elasticity due to stretching and nipple distortion. These factors require a tailored approach and often necessitate more extensive surgical intervention.
So how do surgeons approach mastopexy in these challenging cases?
Yeah.
Are traditional techniques modified, or are there specific approaches designed for massive weight loss patients?
The key is to carefully assess the degree of sectosis, the amount of excess skin, and the patient's overall goals. While traditional mastopexy techniques can be adapted to address these issues, surgeons often utilize innovative approaches like dermal suspension, auto-augmentation mastopexy.
Dermal suspension auto-augmentation mastopexy. That's quite a mouthful. Can you break down what that technique entails?
It's a remarkable technique that leverages the patient's own excess skin and tissue to create both volume and support. Essentially, the surgeon crafts a dermal flap from the excess skin and suspends it from the chest wall, creating an internal scaffold that lifts and reshapes the breast.
Wow, that's ingenious. It's like recycling and repurposing the excess skin to rebuild the breast. Are there any other special considerations within mastopexy that we should touch upon?
Yes, let's talk about tuberous breast deformity, a complex developmental condition that can significantly impact breast shape and appearance.
I'm not as familiar with that term. Can you explain what tuberous breast deformity is and how it affects the breasts?
In tuberous breast deformity, the breasts develop abnormally, often resulting in a constricted base, a high inframammary fold, and herniation of breast tissue into the areola, giving the breast a tubular or constricted appearance.
That sounds challenging to address surgically. What are the treatment goals and options for patients with this condition?
The primary goals are to expand the breast circumference, release the constricted tissues, lower the inframammary fold, and reshape the areola to achieve a more natural and harmonious breast contour. Augmentation with implants is frequently necessary to restore volume and create a more aesthetically pleasing shape.
It's amazing how plastic surgery has evolved to address such a wide range of breast concerns. But with all these mastopexy techniques and variations, what can patients realistically expect in terms of long-term outcomes? We've talked about mastopexy not being a permanent fix, but what about specific measurable changes that patients can anticipate?
That's a crucial question. While mastopexy can significantly improve breast shape and position, it's important to remember that it's a procedure, not a time machine. Gravity and the natural aging process will continue to exert their influence over time, and the breasts will continue to evolve.
So managing expectations is key. What about the longevity of the lift itself? Do certain techniques tend to hold up better over time than others?
Studies have shown that techniques that prioritize inferior parenchymal support rather than relying solely on the skin envelope tend to yield more durable results. This highlights the importance of choosing a surgeon experienced in these methods and understanding the nuances of different techniques.
Expertise and a thorough understanding of the underlying anatomy are certainly essential. Are there any studies or surveys that shed light on patient and surgeon satisfaction with various mastopexy approaches?
Interestingly, surveys of board-certified plastic surgeons have revealed that periareolar techniques, despite their popularity, tend to have higher rates of both surgeon dissatisfaction and revision procedures.
That's an important piece of information for patients to consider when weighing their options. It seems like choosing the right technique is a delicate balance between achieving the desired aesthetic outcome, minimizing visible scarring, and ensuring long-term durability.
Precisely. And I think this underscores a crucial point for both patients and surgeons. Open communication, realistic expectations, and a shared understanding of the potential outcomes, both positive and less desirable, are absolutely paramount.
Absolutely. Informed decision-making is the cornerstone of any successful surgical journey. Well, I think we've covered an incredible amount of ground in our exploration of mastopexy. We've journeyed through the causes of mitosis, dissected the intricacies of various surgical techniques, and delved into the special considerations that often arise in this fascinating field.
And we've only just scratched the surface. The world of plastic surgery is constantly evolving with new techniques and innovations emerging all the time.
You're absolutely right. There's always more to learn and discover. But before we get ahead of ourselves, let's take a moment to synthesize the key takeaways from our deep dive into mastopexy. We'll be right back to wrap up this episode and leave our listeners with some food for thought. Welcome back to our deep dive into mastopexy. We've covered a lot, from the underlying causes of saposis to the various surgical techniques.
Yeah, we've also explored those special considerations like combining it with augmentation, the needs of patients after explantation, and addressing ptosis in those who have had massive weight loss.
It's been quite the journey. But before we wrap things up, I want to circle back to a crucial aspect. Long-term outcomes. We talked about mastopexy not being a permanent fix for ptosis, but I want to dive deeper into specifics. What can patients really expect in terms of measurable changes, and how do those changes play out over time?
Well, long-term studies have actually provided some valuable insights into that. One consistent finding, regardless of the technique used, is that mastopexy doesn't reliably increase breast projection or upper pole fullness in the long run.
So even with surgery, those aspects are still influenced by other factors.
Exactly. Gravity and the natural aging process will always play a role. They gradually affect the shape and position of the breasts over time. And this highlights the importance of setting realistic expectations and understanding that mastopexy is a procedure designed to enhance, not permanently alter, the natural course of aging.
Makes sense. What about nipple position? Does that tend to remain stable after surgery, or is there a chance for the nipples to migrate over time?
Studies focusing on vertical scar procedures have shown that while there is an initial upward shift in nipple position immediately after surgery, the distance from the inframammary fold to the nipple tends to stabilize over time. So this suggests that pseudoptosis, that subtle drooping of the breast parenchyma below the fold, is less likely to recur after a well-executed mastopexy.
That's reassuring. So the lift itself might settle a bit, but the nipples generally stay put in their surgically repositioned locations. Are there any other key takeaways from the research on mastopexy outcomes that patients and surgeons should be aware of?
One notable finding from a review of mastopexy and reduction studies is that nipple overelevation occurs in a significant proportion of cases, specifically around 42%. This emphasizes the need for a really meticulous surgical technique and a thorough understanding of the factors that can contribute to nipple malposition.
So a delicate balance between achieving enough lift and avoiding those positional issues with the nipple and areola. It really highlights the importance of surgical precision and an eye for those aesthetic details.
Precisely. And it reinforces the value of open communication between the patient and the surgeon. Realistic expectations, a shared understanding of potential outcomes, and a willingness to address any concerns openly and honestly are crucial for a successful and satisfying surgical journey.
Couldn't agree more. Well, I think we've navigated the depths of mastopexy with remarkable thoroughness. Any final thoughts for our listeners who might be considering this procedure or just want to learn more about this evolving field?
Mastopexy is really a highly customizable procedure. It offers a whole range of options to address different degrees of ptosis and individual needs. Understanding those nuances of the different techniques, their advantages and potential drawbacks, and the long-term implications is essential for making informed decisions. Finding a skilled and experienced surgeon who prioritizes patient education, open communication, and a tailored approach is also paramount.
Excellent advice. As always, we encourage continued learning and exploration. The world of plastic surgery is constantly advancing and staying informed empowers both patients and practitioners. A huge thank you to all of our listeners for joining us on this deep dive into the fascinating world of mastopexy. Till next time, keep those minds curious.